Okay.
We're going to go ahead and get started. For those of you attending today, this is our first in our series of first-year student grand rounds. That's true for those of you that are watching it via the internet. So what you're going to see today are a group of first-year students who have been assigned a case, and their goal is to present that case, the latest research, the latest treatment, the latest everything about it. And during the session, we are distributing 3x5 cards. Anything they mention is fair game. So if you have a question about what they're talking about, feel free to write it in a 3x5 card, and the people up here will be researching it. We also have Dr. McGowan, who is one of the moderators. Let me give you the mic to say hello.
Hello, everybody, and welcome. I do have a quick announcement that if you are in the PCM 1 o'clock lab group, first of all, check Blackboard again because there's been schedule changes as of even this morning. So check again to make sure your time and room number and group number hasn't changed. And if you are the 1 o'clock group, sit in the back so that at 12:55 you can walk over there and not disturb the rest of us.
So with that, let's turn it over to Group 1.
Thank you, Dr. Dubin. Thank you, Dr. McGowan. We are Group 1, presenting Case 11, 2015, a 28-year-old woman with a headache, fever, and a rash. I'm student Dr. Keith Andrews, and I will be discussing our patient history and presentation. Our patient was a 28-year-old woman who came to the emergency department because of a headache, a fever, and a rash that started that morning. She noticed that the headache was worse with movement, and it did not respond to any treatments like acetaminophen or ibuprofen. She said the headache radiated into her neck, causing mild neck stiffness, and there was a rash on her abdomen, chest, and right arm. The patient reported having bacterial meningitis at age 9. What's interesting is that she said her current symptoms were very similar to the symptoms she experienced with that previous childhood infection. Other than that, she only had 2 hospitalizations, one following a motor vehicle accident, and one for the passage of a kidney stone, which was approximately 10 months prior to this event. She had no known drug allergies, and she was taking citalopram and a combined estrogen-progestin oral contraceptive. For her social history, the patient reported not having any contact with sick persons, she was not sexually active, and she had not recently taken any foreign trips. She worked as an attorney at a local law firm, and she described herself as a non-smoker who rarely consumed alcohol and did not use any illicit drugs. Lastly, the patient did not report any immunodeficient or autoimmune diseases in her family history. Once again, the morning of arrival is when our patient first started experiencing her symptoms. She woke up with a headache and some nausea, which led to one episode of a non-bloody, non-bilious emesis. After that, she went back to sleep. Several hours later, she woke up again, still had the headache, but some new symptoms as well, myalgia, a fever, and a rash. At this point, she decided to come to the emergency department. Our physical exam revealed the following. She had a mildly elevated temperature at 99.1 degrees. Her heart rate was 92, her blood pressure 122/68, and her resting respirations were 18. We found petechiae on her chest, abdomen, and thighs. What you can see here is an image of the rash on her abdomen. We characterize the rash as non-palpable and non-pruritic. We also found neck stiffness, and the patient was alert and oriented to person, place, and time. At the end of our examination, we ordered blood work and a lumbar puncture, and we obtained a urine sample. Now, after her cultures were obtained and sent to C&S, we administered the following empirical drug therapy: 2 antibiotics, vancomycin and ceftriaxone, 1 antiviral, acyclovir, and an anti-inflammatory corticosteroid, dexamethasone. These are the laboratory values we obtained from her tests. Notice the white blood cell count is elevated at 15,000, with 93% of that being neutrophils. Typically, we would expect to see a white blood cell count between 4,500 and 11,000, with only 40 to 70% of that being made up of neutrophils. On the flip side, her lymphocytes were decreased to 4.1%, whereas we would typically expect them to be between 22 and 44%. Lastly, her platelet count was at 90,000, whereas we would expect it to be between 150 and 400,000. These are the results of her lumbar puncture. Notice that her nucleated cells are elevated at 217, with virtually all of them being neutrophils. Typically, we would expect the nucleated cells to be between 0 and 5 cells per cubic millimeter. Also at this time, we determined the patient was negative for respiratory syncytial virus and negative for influenza virus. However, her urine sample did come back as abnormal for red blood cells, renal tubular cells, and albumin. So it was sent off for culture. Now, 90 minutes after she first came to the hospital, we saw a rapid progression in her symptoms, particularly her fever rose from 99.1 degrees to 102.2 degrees, and her heart rate followed, going from 92 to 122 beats per minute over the course of an hour and a half. This rapid progression heightened our awareness that this could be a severe situation. 3 hours after that, which is 4.5 hours into her time at the hospital, we found additional petechiae on her trunk, arms, and legs. You can see the image of the rash from before. Now you can see the rash on her right shoulder has greater density, although it was still non-palpable and non-pruritic. We continued the empirical drug treatment, and we administered IV fluids to replenish her low electrolytes. Lastly, this is when the patient was formally admitted to the hospital. This chart compares the laboratory results we obtained earlier in the day with some laboratory results from the end of the day, 11 hours after her arrival. You can see that by the end of the day, her white blood cell count had risen again to 29,900. Her neutrophils had decreased slightly, but that was offset by the band forms going from 0% earlier to 9.5% after 11 hours. Also, her lymphocytes continued to decrease throughout the day, falling to 0.9% after 11 hours. Lastly, her platelet count was slightly improved to 101,000, but it was still below the reference range of what we would expect between 150 and 400,000. Some other laboratory findings that need to be mentioned: her PTT, fibrinogen, haptoglobin, and LDH were all normal. Also, her D-dimers were mildly elevated at 785 nanograms per milliliter, whereas we would expect them to be less than 500, and there was no overt DIC. This table summarizes the symptoms and findings of our physical examination throughout the day. I would now like to introduce student Dr. Justin Armstrong to further discuss our patient and our differential diagnosis.
Thank you, student Dr. Keith Andrews. I am student Dr. Justin Armstrong, and I'm going to discuss our patient's differential diagnosis today. To quickly recap, our patient had a temperature of 39 degrees Celsius, a heart rate of 122 beats per minute, a respiratory rate of 18 breaths per minute, and a white blood cell count of 29,900. This qualified our patient to be diagnosed with systemic inflammatory response syndrome. To have this, a patient must have 2 of the 4 qualifying symptoms. They must have a temperature of above 38 degrees Celsius, with our patients being 39, a heart rate of above 90 beats per minute, with our patients being above that 122, a respiratory rate of above 20 breaths per minute, with our patient falling short at only 18, and a white blood cell count of above 12,000, with our patient having well over double that at 29,900. I would like to point out our patient's vasculopathy. As seen in the picture here, we can see our patient's petechiae and palpable purpura. Also, she had no bullae, no gangrenous changes, or crepitance. She had no purpura fulminans and no significant erythema. When classifying the causes for systemic inflammatory response syndrome, we put them into 2 categories: non-infectious causes and infectious causes. When looking at the non-infectious causes, we ruled out recent trauma and surgery for our patient. Additionally, because of our patient's acute onset of SIRS, we were able to partially exclude chronic inflammatory diseases like systemic lupus erythematosus. When looking at infectious causes, our patient's urine analysis did show bacteria, but because our patient showed no signs of a UTI when presented at the emergency department, and also the administration of antibiotics, this could be ruled out of our diagnosis. Additionally, our patient showed no crepitance. This allowed us to partially exclude necrotizing fasciitis. This led us to think that our patient had some sort of infectious meningitis. When looking at the causes for infectious meningitis, we classified them into 3 categories. Viral meningitis, which could be caused by parvo or cytomegalovirus, aseptic meningitis, which can be caused by herpes simplex 1 and 2 virus, and bacterial meningitis. Viral meningitis can be partially excluded because of our patient's high neutrophil content and low lymphocyte content. Additionally, aseptic meningitis could be ruled out for the same exact reason, which led us to think that our patient had some sort of bacterial meningitis. When looking at the causes for bacterial meningitis, there are many organisms that come to mind. Streptococcus pneumonia is the most common, but because our patient had vasculopathy, this could be partially excluded. Streptococcus aureus could also be partially excluded because our patient had purpura. Haemophilus influenza is not common in adults and therefore can be partially ruled out in our 28-year-old patient. Our patient said that she was not currently sexually active and therefore Neisseria gonorrhea we could partially exclude. Our patient had no known tick bites and therefore Rickettsia rickettsii could be partially excluded. This led us to believe that our patient was infected by Neisseria meningitidis. Our patient's blood culture was sent out for gram staining and spectroscopic analysis. As seen at the picture here, our patient's gram stain and spectroscopic analysis confirmed that our patient was infected by Neisseria meningitidis. When looking at meningococcemia by Neisseria meningitidis, it is important to note that it is the second most common pathogen causing meningitis in 18 to 64-year-old patients. Commonly, we find patients having sepsis, purpura, and petechial rash, all of which our patient had. It is important to note that our patient had previously received a vaccine, but her current infection is thought to be from a different serogroup. When looking at the graph here, it is important to note that the burden of the disease is most severe in our patient's age group. When looking at the additional risk factors for meningococcal disease, 4 things can be ruled out for our patient: hypogammaglobulinemia, splenectomy, immunosuppressive drugs, and systemic lupus erythematosus could be ruled out because of our patient's symptoms upon presentation to the emergency room. Additionally, HIV and complement deficiency should be tested for in our patient. Our colleagues came up with a tentative diagnosis of meningococcemia by Neisseria meningitidis. When looking at our patient's lumbar puncture findings, there are some things that are worth noting. Our patient had a clear and colorless cerebrospinal fluid, which is typically cloudy in meningitis patients. Additionally, our patient had normal protein levels, which is typically elevated because of the presence of bacteria, and our patient had normal glucose levels, which is typically decreased because of the bacteria metabolizing the glucose. Additionally, our patient had a white blood cell count of 217, which 100% of which was neutrophils, indicating, again, a bacterial infection. Our patient had a red blood cell count in her cerebrospinal fluid of 340, which is thought to be from a traumatic tap rather than the infection itself. Our patient showed no organisms in her cerebrospinal fluid, evident via a gram stain. When looking at clinical manifestations of community-acquired meningitis in adults, there are 2 things worth noting. Our patient's normal cerebrospinal fluid protein level, as we just stated, is only found in 4% of adult meningitis patients. Additionally, the rash found on admission on our patient is only found in 11% of patients. When looking at our patient's atypical findings, there are some things worth noting. In typical bacterial meningitis patients usually have severe purpura, DIC, low CSF glucose levels, high CSF protein levels, and occasionally we will see organisms in our patient's CSF. For our patient, we had very little purpura, no DIC, normal CSF glucose levels, normal CSF protein levels, and again, our patient had no organisms in her CSF. Additionally, our patient had had bacterial meningitis once before. This led us to think that she possibly had some sort of immune deficiency. To test for immune deficiencies in our patient, we first performed a T-cell independent B-cell function test and a T-cell dependent B-cell function test. Both came back with normal levels of IgG, IgA, and IgM antibodies. This indicated a healthy adaptive immune system and shifted our focus more towards the innate immune system. When looking at recurrent bacterial meningitis from culture to cause, there are 2 things worth noting. Anatomical defects that can be caused by trauma can increase the recurrence risk of Neisseria meningitidis infections by around 10%. Additionally, complement deficiencies can increase the recurrence of Neisseria meningitidis infections by 75 to 100%. When looking at the complement system, it is important to note the 3 pathways. There's the alternative, the lectin, and the classical. All converge on C3b and form the complement cascade, which ultimately forms the membrane attack complex that will lyse extracellular bacteria like Neisseria meningitidis. To test the complement system, there are two tests that are performed. There is a CH50 test that tests the classical pathway via hemolysis, and if decreased hemolysis is present, it shows that our patient has some sort of complement deficiency. Additionally, an AH50 test is done that will test the alternative pathway. This is used to determine if the complement deficiency is just in the classical pathway or a terminal complement deficiency. For our patient, we first performed an CH50 test. The hemolysis results showed it was abnormally low, indicating our patient had some sort of complement deficiency. We additionally went on to perform an AH50 test, which again came back lower than normal, indicating our patient had some sort of terminal complement deficiency. Because of this, we did a complete component analysis on our patient and found that our patient was deficient in C8. Again, when looking at the complement system as a whole, it is important to note where C8 inhibits the formation of the membrane attack complex that doesn't allow for lysis of bacteria. It is important to note that the alternative, lectin, and classical pathways are allowed to proceed and the opsonin C3b is still formed. When comparing meningococcal disease in typical patients to that of terminal complement deficient patients, there are three things worth noting. The frequency of infection in terminal complement deficient patients increases to 58% compared to the almost 0.0072% in normal patients. Additionally, the reoccurrence of meningococcal disease in terminal complement deficient patients increases to 44% compared to the just 0.34% in normal patients. Most importantly and counterintuitively, the mortality rate decreases in patients with a terminal complement deficiency to 1.5% from just 19 in normal patients. To further talk about our final diagnosis and management, I would like to introduce Tasfia Ahmed.
Thank you. Oh, is it on? Thank you, Student Dr. Justin Armstrong. My name is Student Dr. Tasfia Ahmed, and I will be talking about final diagnosis and management. So just to reiterate, we are dealing with a patient who has been diagnosed with recurring meningococcal meningitis with primary C8 complement deficiency. So what does this mean for our patient, and how can we manage her condition? In this case, we saw that C8 deficient individuals are more susceptible to Neisseria meningitidis. However, we saw that there is decreased severity of symptoms and they are less likely to die. As Student Dr. Justin Armstrong mentioned, in normal individuals, the mortality rate is 19% when infected with Neisseria meningitidis. However, in terminally complement deficient individuals, the rate dramatically decreases to 1.5%. So why is this? In normal individuals, complement proteins C5, 6, 7, 8, and 9 come together to form the membrane attack complex, MAC, to form transmembrane protein channels that disrupt the phospholipid bilayer, resulting in cell lysis and cell death, releasing endotoxin into circulation. This results in increased inflammatory response. However, in normal individuals without complement 8, MAC complex is not formed and cannot lyse Neisseria meningitidis. As a result, we see decreased levels of inflammation and the atypical presentation in this case. Now, in terms of management, our main goal is to treat our patient is to save her life, prevent future infections, as well as treat her current symptoms. From her blood test results, we found that our patient's infection was sensitive to ceftriaxone. As a result, we recommended a 7-day course of intravenous ceftriaxone, which is a cephalosporin antibiotic that treats gram-negative bacteria. Upon administration of this drug, we found that our patient's symptoms cleared up, her fever and rash decreased dramatically. Furthermore, we recommended close contacts who may come in contact with respiratory secretions from our patient be given rifampin as a prophylactic measure. Our patient was discharged within 2 days, and we recommended seeing her again within 2 weeks, as well as after 5 months. We also recommended repeat vaccinations in order to boost her immune response, as well as potential OMM treatments and patient education to prevent future infections. At the 2-week follow-up visit, our patient was doing much better. At this time, we gave her repeat vaccinations, in particular for Menactra, which has been shown in a recent study to reduce meningococcal infection by 4.5 times. We also recommended pneumococcal conjugate vaccine 13, as well as a vaccination against Haemophilus influenza type B in order to prevent infection from other meningitis-causing bacteria. We also recommended, as a prophylactic measure, moxifloxacin, which is a broad-spectrum antibiotic, in case of recurring symptoms of meningitis. A typical dosage is 400 milligrams given daily for about a week. When we saw our patient again at the 5-month mark, complement 8 deficiency had been confirmed at this time. We gave her the second dose of Menactra, and Menactra protects against serogroups A, C, Y, and W135 for Neisseria meningitidis. However, we also recommended vaccination against serogroup B, which is another pathogenic strain. However, this vaccine was not available in the US, and our patient had to go to Canada in order to get her vaccine. We also recommended immediate relatives be tested for deficiency, and we found that her sister also tested positive for C8 deficiency. In terms of OMM treatment, light lymphatic drainage techniques can be helpful to increase immune function. However, at this time, there is no conclusive evidence-based research available. Now, patient education is extremely important in order to prevent recurrences of infection. Particularly, a recent study has found that complement-deficient individuals are 7,000 to 10,000 times more susceptible to Neisseria meningitidis. They are also susceptible to Neisseria gonorrhea. As a result, in order to prevent future infections, we recommend staying up to date with immunizations, using barrier methods to prevent STIs, as well as timely medical treatment in case reinfections do occur. Genetic counseling is also suggested in terms of family planning for our patient. And finally, the Immune Deficiency Foundation, as well as UpToDate, has immunization handouts as well as information available to prevent future infections in our patient, as well as to inform the patient and her family on how to lead a better quality of life. And finally, I'd like to address an ethical issue that was brought up by this case, the safety of vaccination in other countries. So in this case, our patient had to go to Canada to get her vaccine. So Canada does have a rigorous testing process. They have a similar process just like Canada in order to approve their vaccinations, and so it is safe. But what about patients who can't get their treatment here? Is it okay for them to go to another country? This vaccine has been since approved in the US, so we know that it is okay for a patient. Another thing to consider is the type of patient that is being treated. So in this case, our patient didn't have any dependents. She had family support and was able to afford getting treatment in another country. But is this okay in all cases? What if the patient does not have the finances to go somewhere else or doesn't have insurance to go for the follow-up visits or get her other vaccines? What do we do in those cases? And finally, another thing to consider is the legal issues. What are the consequences of adverse reactions that could occur if someone is to go somewhere else for treatment? Who is responsible? Is it the doctor? Is it the patient? Is it the doctors in the other country? So these are some things to address. And with that, I'd like to conclude our presentation. I'd like to thank all of the professors that helped us with this case in this presentation. Thank you very much for all of your feedback. And I'd like to thank our team members sitting next to me here. They were wonderful doing research. Thank you very much. And with that, I'd like to open the floor for questions, comments, and concerns. Thank you.
Great job, you guys. It's tough being the first group, and I think you guys did an excellent job. I think the faculty agree. So I know there's several questions, so which side is kind of ready to go? That side? All right. Go ahead.
I can go first. So one of the questions that we received was, what antibiotic would you use for prophylaxis after exposure of students living in a dorm to N. meningitidis? So according to clinical pharmacology, rifampin is often used for asymptomatic carriers of this bacterial species. And its mechanism of action is that it inhibits RNA transcription. And this drug doesn't bind to the eukaryotic form of RNA polymerase, so it doesn't affect the human cells, and it only affects the bacterials.
So our next question was, oops, sorry. Can I just take this off? So another question we had was, what is DIC and how did you know that your patient didn't have it? So DIC is short for disseminated intravascular coagulation, and basically what it is that it's an imbalance between the body's coagulation and anticoagulation system. And so in DIC, you have an abnormal activation of the coagulation system. So you start to form these microthrombi within blood vessels, which can reduce blood flow into different tissues and organs. And also at the same time, since you use up all the platelets to form those microthrombi, you now have a deficiency of platelets, so you're more likely to bleed out. And how did we know our patient didn't have it? Usually DIC is characterized by purpura fulminans, which is, you see more like necrosis of the tissues. And, yeah.
How about in your laboratory values? Do you have kind of what you would have seen, how you went through the fibrinogen and such, and what your patient had and what they would have in DIC? Do you have that?
We had a little bit of an elevated D dimer, which can be indicative of DIC, but the thromboplastin time, which is kind of a measure of how fast the blood coagulates, those values were normal, which means that she didn't take too long for the blood to coagulate. So.
Okay.
So we were asked why the patient was given dexamethasone in addition to the other medications. Dexamethasone can be indicated when there is just empirical evidence of an acute meningitis infection. The reason being that you're kind of worried about both inflammation from the infection kind of running wild, and so you want to control that a little bit, particularly in the central nervous system, and dexamethasone has good penetration to the central nervous system. So potentially administering dexamethasone as an adjuvant to the other medications could reduce the risk of some of the central nervous system complications that can come from an infection with meningitis.
All right. The next question that we had are, what are bands? Dealing with band cells. So band cells are immature neutrophils, and the bands are the nuclei. They haven't separated into a bunch of different nuclei because neutrophils are multinucleated cells. And so, for instance, in our patient, if they have large amounts of bands in their blood, there's a left shift, which means that that the patient has an infection, and so the body is creating more neutrophils and releasing neutrophils, which means that immature neutrophils are being released.
Let's go ahead and go back to surveys.
Question is, what is a Brudzinski sign? Brudzinski sign is when a patient has severe neck stiffness, which causes a patient's hips and knees to flex. And it's a symptom of meningitis.
So one of the questions we had was, should a CT of the head be ordered before doing a lumbar puncture? So for our particular case, they didn't actually do a CT of the head, and we're not exactly sure why, but it was most likely due to the fact that her condition was progressing rapidly. But usually you would order a CT of the head before a lumbar puncture in order to rule out any lesions or intracranial abnormalities that could lead to cerebral herniation from a lumbar puncture, but it wasn't done in our case.
So for meningitis, there's the three tests that or signs that you can see in a meningitis case. You can see the nuclear rigidity. You can see the Brudzinski's test. And then also there's the Kernig's test, which is you get the thigh of the patient and you bring it up to a 90-degree flexion, and you won't be able to bring it to a 90-degree flexion if they have meningitis. That'll be too much pain. And so that's another sign that you have a meningitis case.
Okay, so this question is, what is the Waterhouse-Friderichsen syndrome? And it is a failure of the adrenal glands due to Neisseria meningitidis infection, and it is caused by a bleeding of the adrenal glands, which leads to overwhelming meningococcinemia, and it's treated with ceftriaxone.
That's all our questions. Does any faculty want to say anything, any comments?
I just make a comment with regard to the last lady on the end that answered the question relevant to the CAT scan prior to the LP. The only hesitancy, reason why I wrote that is because she had meningitis at age 9. And as a sequelae from that, we really don't know what her brain looked like and could there have been any potential midline shifting. Having said that, obviously she hasn't. They made the right decision. But in the standard of care today, an LP is the right protocol, but it's usually preceded by a CT. Okay? Thank you.
So you just heard from an old timer in internal medicine, and that's good. But certainly in a pediatric population, we don't routinely get CTs if all the clinical signs there and there are no signs of strong neurologic deficit other than that stiff neck. So often the CAT scan is not done, and pediatricians will go right for an LP. Comment on the DIC thing. The reason your patient didn't have a DIC is her PT and PTT, and I think fibrinogen were all normal, which kind of rules out that possibility of a DIC, although her platelet count was low. So she probably had, let's call it one in evolution, but the fact that she was C8 deficient decreased her inflammatory response, and hence the DIC didn't completely develop or evolve. I suspect it probably would have over time had they not started her on appropriate antibiotic therapy to treat the underlying cause. So I don't know, what do you think about that, Dr. McGowan?
I agree.
In respect to my dean, the fact that she's 28 years old now, the fact that she works in a law office, that heightens my antennas to go ahead and do a CT prior to the LP. Thank you.
So what you've just learned is that old people are afraid of lawyers, but that's okay.
I have a question for the clinicians. Okay, so the platelets counts that student doctors presented. How about the morphology of the platelets? Are they in the resting or they are activated? Because if they are activated, they are whole different. Any insight?
I don't think there were any platelet function tests done on this patient.
And it's not so much the quantity, it's the quality of function. So I said it's not so much the quantity in this particular case, it's the quality of function. And just at 90,000 platelets, I mean, you can bleed at 150,000 platelets. So hence the quality of function is not great. In this particular case, that really wasn't a concern. My biggest concern would have been when they looked in the eyes, was there any papilledema or evidence of hemorrhaging elsewhere as due to deficiency of quantitative platelet function. Yeah, petechiae are, just as you guys know, immunological manifestations of inability to clot or ongoing bleeding, and that showed up in the skin. But you can see them on the buccal mucosa, the conjunctiva of the eyes. You can see them in a lot of places.
Okay, with that, great job, and we'll switch to group 2.
Thank you everyone for attending our presentation. We are group number 2, presenting case 20 from 2014, a 65-year-old man with dyspnea and progressively worsening lung disease. These are the members of our group. And I'm student Dr. Ranjot Basram, and today I will be going over the clinical presentation portion of our case. The patient was well until 3 years before admission when he presented with a herpes zoster infection. Shortly after, bloody diarrhea developed, and a diagnosis of colitis, which is characterized by inflammation, sores, and swelling on the inside lining of the colon was made. 2 years before admission, mesalamine, which is an anti-inflammatory agent, was administered and improved the symptoms of the patient. But during the next 2 years, progressively worsening dyspnea, which is difficult or labored breathing, occurred in the patient. 1 year before admission, pulmonary function tests were performed, and the results supported a diagnosis of a chronic obstructive pulmonary disease. Tiotropium bromide, which is a vasodilator, was administered at this time to the patient by inhalation. 6 months before admission, numerous episodes of dyspnea worsened. Supplemental oxygen at this time was administered to the patient at a rate of 2 liters per minute at an as-needed basis. Gradually, lower and lower doses of a steroid called prednisone were administered to the patient to help in the inflammation that was involved in the difficulty in breathing in the patient. These treatments showed temporary and short-term improvement. 5 months before admission, a cough with sputum production developed. A CT scan of the chest was also performed at this time, and a new irregular nodular opacity was seen in the right lower lobe, measuring approximately 1.8 centimeters by 1.4 centimeters. The pulmonary artery was dilated, indicating pulmonary hypertension, which is commonly seen in patients with chronic obstructive pulmonary diseases. 3 months before admission, a stress echocardiogram showed fair to poor exercise capacity, which was consistent with the left ventricular ejection fraction value of 65% in comparison to the normal values of 50 to 60%. 3 weeks before admission, dyspnea on exertion worsened in the patient, and a non-productive cough and a temperature of 37.8 degrees Celsius were associated with his symptoms. The patient was unable to walk even short distances to his home. At this time, supplemental oxygen levels were increased to 4 liters per minute at a rate of 24 hours a day. 2 days later, the patient was transferred to the other hospital. The patient's respiratory status worsened. His supplemental oxygen was increased to 80% saturation to maintain an 85 to 90% saturation level inside the patient's body. Prednisone treatment was stopped, and a steroid methylprednisolone and trimethoprim sulfamethoxazole were administered to the patient at this time. An echocardiogram at this time also showed a normal left ventricular ejection fraction value of 50%. After 9 days at the other hospital, the patient was transferred to the Massachusetts General Hospital for further treatment. On arrival, the patient's temperature, blood pressure, and pulse were all normal. However, the respiratory rate was elevated at 24 breaths per minute compared to the normal respiratory rate values of 12 to 16 breaths per minute. Oxygen saturation levels of the patient on arrival were at 67%. This was along with the oxygen supplementation at a rate of 4 liters per minute through a nasal cannula. This rose to 89 to 90% oxygen saturation levels in the patient when the oxygen supplementation levels were increased to 10 liters per minute through a face mask. The remainder of the patient's examination was normal. On arrival at the Massachusetts General Hospital, the patient's past medical history included hypertension, hyperlipidemia, depression, no known allergies, no exposure to irritants, and a 50-pack year smoking history. Approximately 3.5 hours after the patient's arrival, the patient's lab data showed leukocytosis and lymphopenia, along with a percentage decrease in albumin levels. And now my colleague, student Dr. Stephen Barna, will go ahead and address the differential diagnosis portion of our case.
Thank you, student Dr. Ranjot. I'm student Dr. Stephen Barna, and I'll be presenting the differential diagnosis. So the initial concern upon presentation of the patient was what is causing his worsening dyspnea. Now, most patients with chronic dyspnea have a condition that falls into one of 4 broader categories, including obesity, cardiac disease, COPD, or interstitial lung disease. We must rule out any potential category as a possible cause for the patient's worsening dyspnea. Obesity would not explain the degree of hypoxemia observed, and an extensive cardiac evaluation was performed, and no correlations could be drawn to the patient's worsening dyspnea. The patient had a long history of smoking and showed improvement upon glucocorticoid and antibiotic treatment. Furthermore, radiological findings were similar to those presented in interstitial lung diseases. Therefore, these two could be possible differential diagnoses. X-rays of the patient 5 months prior to admission and during admission are shown above. And I would like to call your attention to the patient's X-ray upon presentation, which has an arrow pointing to a new opacity not seen in the patient's previous radiographs. These opacities are referred to as ground glass opacities and can be seen on the patient's CT scans. Ground glass opacities signify partial filling of air spaces by exudate, fluid, blood, and interstitial thickening. As indicated by the arrow, these ground glass opacities are predominant in the right middle lobe, are entirely new, diffuse, and isolated. And in this context, when I use the word isolated, I simply mean they are not associated with other radiological findings. Now, the differential diagnosis for ground glass opacities can be very broad. However, since these are isolated, the list of differential diagnoses is therefore very limited. So we begin by narrowing down some of the differential diagnoses associated with isolated ground glass opacities, starting with interstitial lung disease. This can be accomplished by comparing the patient's symptoms to characteristics associated with interstitial lung disease. Most occur bilaterally. However, this patient's disease was predominant in the right middle lobe. Furthermore, the acute progression of this patient's disease occurred over the period of a few weeks, compared to the onset of most interstitial lung diseases, which usually take a period of a few months to develop. Therefore, this is a less likely differential diagnosis. Pulmonary workup came back and showed no reason to suspect any alveolar diseases. This is also coupled to the fact that most alveolar diseases occur bilaterally. Therefore, this is also a less likely differential diagnosis. Now, drug toxicity must be taken into account, as it was known that the patient was receiving various drugs associated with ground glass opacities. However, of all of his drugs, only mesalamine was known to show the symptoms of non-productive cough, dyspnea, and low-grade fever. The problem is that mesalamine is not associated with isolated ground glass opacities, and therefore, drug toxicity is a less likely differential diagnosis. 8 days prior to admission and during admission, the patient presented with lymphocytopenia. Lymphocytopenia causes a decreased defense against microbes, and patients are therefore vulnerable to infections that would routinely be evaded by persons with healthy immune systems. Since opportunistic infections occur in patients with suppressed immune systems, we next consider the 4 opportunistic infections associated with isolated ground glass opacities. RSV, herpes simplex virus pneumonia, CMV, and pneumocystis pneumonia are these 4 opportunistic infections. RSV affects bronchiolar epithelium, which obstructs and increases airway resistance, and therefore wheezing is common. RSV is also common in elderly and is associated with increased risk with COPD. However, the patient did not present with other symptoms commonly associated with RSV, including coryza, rhinorrhea, sinusitis, or conjunctivitis. Therefore, RSV is a less likely differential diagnosis. The patient also did not present with any oral or genital lesions, leaving herpes simplex virus pneumonia as a less likely cause. CMV and pneumocystis pneumonia present with similar symptoms to those expressed in the patient, including non-productive cough, dyspnea, and low-grade fever. Therefore, these 2 could be considered as a differential diagnosis. Initially, the lymphocytopenia was thought to be linked to prednisone use. However, when the absolute lymphocyte count was determined, it was alarmingly low. A lymphocyte count less than 800 cells per cubic millimeter has a 100% specificity for a CD4 T cell count less than 200 cells per cubic millimeter. Therefore, defects in T cell mediated immunity causing a compromised immune system must be considered. HIV is associated with a low CD4 count in patients with pneumocystis pneumonia. The course of an HIV infection goes through 3 phases: the acute phase, chronic phase, and AIDS. At the beginning of the acute phase, the viral protein envelope binds to CD4 T cell receptors and its co-receptor, initiating the infection. The binding allows both viral cell membrane and host cell membranes to fuse, and the viral replication is rapidly incorporated into the host DNA to produce new virus proteins and eventually a mature HIV. As this continues, the viral load quickly increases, which can be seen on the graph in red. At the same time, the CD4 T cell count gradually decreases due to active viral gene expression and protein production, which causes defects in IL-2 and IFN gamma secretion, essential chemokines that, when inhibited, cause T cell anergy. Now, your body fights the infection back, causing the viral load to decrease, as seen in red on the graph, entering the chronic phase. However, your CD4 T cells continue to be suppressed, and when your count gets to around 200 and below, then you are at a very high increased risk for opportunistic infections. In patients with HIV, this constitutes the final stage of AIDS. So with this in mind, a final diagnosis of pneumocystis pneumonia with HIV infection was made. Immunofluorescence assay specific for P. vechi from sputum established pneumocystis pneumonia, and a diagnostic test for HIV antibodies confirmed the HIV infection. Although not mentioned, an ELISA P24 antigen detection test could have been used to test for the HIV infection. And ELISA P24 is a component of the HIV caspid. I will now let student Dr. Hannah Baum talk about treatment.
Good afternoon. Thank you for coming. I am student Dr. Hannah Baum, and I will be presenting the treatment portion of our case. After diagnosis with PCP and HIV, the patient was given TMP SMX orally. This is a common treatment for PCP and other types of pneumonia. It works by inhibiting bacterial synthesis of tetrahydrofolic acid, which ultimately slows bacterial resistance. Prednisone was tapered over the course of 3 weeks, likely due to the risk of adrenal suppression. Antiretroviral therapy was done for the HIV, and prophylaxis was done for a Mycobacterium avium intracellular infection. There were a couple of complications with the patient's treatment, one of which was a slow CD4 T cell rebound, which occurs in 10 to 15% of HIV patients. This is indicative of immunologic failure, especially if there is no rebound of CD4 T cells. Transient adrenal insufficiency was also present. This is common in HIV-infected patients. This increases pathogen susceptibility to certain pathogens such as CMV and Mycobacterium, which was being treated. Adrenal insufficiency occurs when the HIV infiltrates the adrenal glands. This reduces the cortisol levels in the body, and cortisol is an inhibitor of pro-inflammatory mediators by inhibition of NF-kappa B. There are some osteopathic treatments that could be done once the patient is in a stable state. They are lymphatic treatments such as doming the diaphragm, rib raising, and the thoracic pump technique. These treatments help augment lymph flow and maximize respiratory function, but they should only be done once the patient is stable. If there is an emergency or an acute problem, that should be addressed first, and these should only be administered once the patient is well enough to handle them. Some topics on emerging treatments are enzyme regulation and viral eradication. There's a study done by the University of Rome on enzyme regulation, and they were looking at a specific enzyme that seems to control the rate of HIV replication. A low presence of this enzyme, called ADAR1, seems to correlate with a lower viral replication, and a high presence of ADAR1 will equal to a higher HIV replication. ADAR1 associates with HIV-1 P55 GAG protein and is incorporated into virus-like particles. UC Davis did a study on an anti-cancer drug called Ingenol 3 Angelate, looking at the potential of viral eradication. This anti-cancer drug potentially can reactivate latent HIV, and when done in conjunction with antiretroviral therapy, it could potentially shock the HIV back into life and eradicate the virus completely from the body. Some legal and ethical considerations in our case include the mandatory notification to the state of Massachusetts by the physician if a Massachusetts physician is treating an HIV-inflicted patient in their clinic. They are not legally allowed to notify anyone else, including other people who are at risk for exposure. This could be a serious ethical issue if the patient who has HIV has a partner who is also being treated by the same physician. If that physician is not able to tell the partner of the HIV-infected person that they are in danger, they could be potentially putting their patient in harm's way. Another issue is physician bias. Our patient was a 64-year-old man who had a chronic history of smoking. This led them to believe he had lung problems, and that was all, which is normal for their experience and training. There was nothing in our patient's past history that would tip them off that he had been exposed to HIV, which actually leads to missed opportunities for HIV testing. There was a low lymphocyte count 8 months before admission, but if they had tested during this time, they would have caught the HIV earlier, reducing the negative effects on the patient. Another thing worth mentioning is there's some question if corticosteroids might induce spontaneous pneumothorax in HIV-infected patients, but it is not extensively supported. The physician is also responsible for educating the patient on his HIV condition. The physician must make sure that the patient understands safe sexual practices, and if they are an intravenous drug user, the safe practices for doing that activity. The physician should also stress professional counseling for their patient having HIV is still a biased thing in society. So this patient might have mental or social issues with having HIV, and counseling might help them cope with those situations better, which are very important for the patient's mental well-being, which can be almost as important as their physical health and their quality of life. At the end of the case, the patient was fully suppressed with HIV. Their HIV was fully suppressed, and they also had pulmonary disease. This is indicative of their CD4 T cell count rising and the antiretroviral therapy working, but the pulmonary disease was still present because emphysema is a chronic condition, although our patient was stable. We would like to thank these faculty that helped us with this presentation. And these are our citations. We are now open for questions.
That was a really nice job. So looks like you guys got a lot of questions during the presentation. Which side wants to start first? Down here? Okay, let's turn the mic on.
Okay, so the first question we have is, what is the mechanism of action of tiotropium bromide in causing vasodilation? In the airways, it exhibits pharmacological effects through inhibition of M3 receptors at the smooth muscle and submucosal glands, preventing smooth muscle contraction and mucus secretion, thus leading to bronchodilation.
Okay. One of the preferred drugs for patients with the chronic obstructive lung disease that's not the reversible type, i.e. asthma. So you'll often hear that. What else do you have?
On that question or no?
No, any other questions you have?
So we have a question, what are the side effects of long-term prednisone treatment? Prednisone has a similar shape and action of cortisol. That is a natural hormone that your body secretes. And after you take this long-term, it can suppress the creation of it from your adrenal glands.
Okay, there's a whole slew more. Do you have anything else?
I do not.
Why don't you go work on that and we'll come back to you, okay? Look up side effects of steroids. What do you guys have?
So one of the questions was, what medication should be given to a patient with HIV whose CD4 count is below 200? We touched on this just a little, but it will be antiretroviral therapy. In our patient, this included reverse transcriptase inhibitor and a pharmacokinetic booster.
Okay, so I think that question was really geared at what do you do prophylactically if someone's CD4 count drops below 200? And the answer is is Bactrim DS, the same drug that you use to do that. Anybody whose CD4 count is below 200 automatically gets placed on that prophylactically to prevent a PCP pneumonia from developing. Any other questions? Pardon? Yeah, I can see that. Steroid guy, you got an answer for us yet?
I'm also reading that it will suppress the immune system, but I haven't read further enough along.
Okay. Posterior capsule cataracts, moon facies, buffalo hump, thin skin, increased blood sugar that could make a patient diabetic, aseptic necrosis of the femoral head, purple stria. There's a whole slew of steroid side effects. And I suggest all the first years, now's the time to learn them because you're going to hear that over and over again. Other questions? Okay, with that, you got one more? Okay.
I have one more. The question was, what would he be at risk of if he had been exposed to asbestos? And so asbestos...
I'm sorry, could you repeat the question again?
If he had been exposed to asbestos, what would he be at risk of?
Okay.
So asbestos is a carcinogen, so he'd be at risk of cancer. It scars lung tissue. It would cause shortness of breath, tightening of the chest. But in our paper, it says that the patient had no exposure to any sort of environmental...
I suspect whoever wrote that question was thinking about mesotheliomas. Yeah, so That's what they were looking at. You guys will hear more about that as year two. Final comments. The presentations were great for both groups. You guys, both groups really did a really nice job on the presentations. So you kind of set the bar real high for those. So good job, and you kind of set the bar for the next groups that are coming in a couple weeks. Well done.